introduce myself a little bit later, but I am broadcasting from beautiful Orlando at the American Institute of Ultrasound and Medicine meeting, only to head on to San Diego for the American College of Physicians Ultrasound pre-course. Dr. Tierney is broadcasting from Minneapolis, and we'll be heading to the ACP course later today as well, so kind of an interesting spread across the country. I think at this point we'll go ahead and get started with our presentation and this webinar. So we'll go ahead to the next slide when we're ready. All right, let's go through our agenda real quick as far as the topics that we'll be addressing. We will want to talk about what are some of the leading internal medicine ultrasound applications, how has ultrasound changed Dr. Tierney's practice in this case, and I'll give his introduction in just a little bit. How does ultrasound improve current standards of care or improve upon them? And how is ultrasound currently being taught? And lastly, we'll follow up with how will bedside ultrasound help provide better care and lower costs? We'll go ahead and move to the next slide. And just a quick word on myself. My name is Mike Blaivas. I am an emergency physician by training, and I've been involved in point-of-care ultrasound for about the last 22 years, having had a chance to do lots of research and education. We'll introduce Dr. Tierney. Dr. Tierney is a pioneer in internal medicine ultrasound. He's a hospitalist and a program director for internal medicine, the residency program at Abbott Northwest Hospital in Minneapolis, Minnesota. He is also the founder and director of the hospital's ultrasound-guided bedside procedure team, which was started in 2006. And in 2010, he founded and continues to direct the internal medicine bedside ultrasound IMBUS program. Dr. Tierney, as I mentioned, is a pioneer in internal medicine ultrasound, lectures all over the country, is involved in so many things that I can't even keep them straight, and I've had the pleasure to work with him on a number of occasions. Next slide. All right, on to our first question for Dr. Tierney. What are leading primary care ultrasound applications?
All right, thanks, Mike. On this first slide here, I think you see a picture of the body from a recent review article, and the answer to this question is really, what do we do as internists? And if we think of primary care ultrasound, internal medicine, in the hospital, in the outpatient clinic, family practice, sort of spanning those two venues, and you think about what we do on a day-to-day basis, listening to hearts and lungs, people with coughs, people with shortness of breath, people with blood pressure up and down. It is a broad answer to this question, but it's really almost everything we do on a routine day-to-day basis. If we get more granular about what that means, I think it's sometimes easiest to split it up into what do internists see inside the hospital and outside of the hospital. And there's some crossover, obviously, but if you take the inpatient sort of main bread and butter, that patient who comes in short of breath and his wife says he's got COPD, he thinks his legs are more swollen and it's his heart failure, and he's got a little bit of a cough, sort of that common conundrum of COPD, heart failure, or something else we see all the time, and we use it a ton for that. That's about 45% or so of what we do is lung ultrasound, and about 30% is cardiac. So between heart and lungs and that short of breath patient, that's by far the biggest inpatient main application. Other things that sort of highlight that inpatient list, hypotensive patients, whether that is a little bit hypotensive and you're trying to sort out fluids or diuretics or what might be going on, or that really hypotensive patient who's in a sinus tach PEA arrest, right? Sort of on the spectrum of just bad hypotension. Along those lines, how far do we diurese someone? the volume, fluid, responsiveness questions. Where are you? How full is your tank? Can I be a little bit more granular and stop diuresing you before your kidneys bump and I have to keep you in the hospital one more day to make sure they come back down? Can I discharge you a day earlier? Kidneys and bladders from sort of below the diaphragm. And then the procedural realm in-house that I'm involved a ton with, but we use procedural ultrasound for almost everything we do on the inpatient procedure team. The common thoroparas, central lines, but also tough, obese lumbar punctures in the ICU on the vent, those patients that don't have good landmarks. And then arthrocentesis and injection. So tons of inpatient pieces, and a lot of those cross over into the outpatient environment as well. But if we highlight one from the inpatient first here, let's go to the next slide there and just show that PEA piece. So a dramatic example, right, is a sinus tac PEA arrest in the house here, and we've all heard H's and T's, but that's a little bit of a waste of time for an in-house sinus tac PEA arrest, which is one of 5 things. Most of the time this is severe hypovolemia, maybe it's blood, maybe it's not, it's a tension pneumo that needs a needle or a chest tube, it's tamponade that needs some fluid and a needle, it's a PE that needs some lytics pushed at the bedside, or it's cardiogenic shock that's severe. And those 5 things make up the vast majority here of in-house PEA arrests that are sinus tac. Those 5 are figured out in about a minute with ultrasound at the bedside. So that image there on the left is all of our code carts in-house here with an ultrasound sitting next to them. So ultrasounds come to every one of our codes, and by and far are used in every single one of our narrow, complex, fast PEA arrests as well. Let's go back and highlight just a couple of the outpatient ones, maybe on that previous slide. And a lot of the short of breath stuff crosses over. It's not quite as severe. It's not intubated ICU patients, but it's that person who came in last year and is back this year because she got a Z-Pak last year for this cough that's been hanging around for a week and is a little bit short of breath, and sort of the decision of, do we need antibiotics here, yes or no? There's a lot of aging internal medicine patients with big prostates and bladder or urinary difficulties. How full is your bladder right now? Do you have a big prostate? What should we do in clinic as the next step? There's a paucity of AAA screening being done from a recommendation standpoint, not meeting near the numbers of appropriate screening. And this is a very easy office-based screen that can have a high impact on your patients. Vascular stuff from a DVT outpatient standpoint is a little bit complex, but can be woven in very nicely to a combination of sort of pretest probabilities and D-dimers and office-based ultrasound. And then I got this thing under my skin, doc, and it's been there for a few weeks, or it's been there for 4 years. Let's take a look at it and see if we can simplify this and just see that it's a little lipoma and move on. So you get the idea there, but the guy on the right really shows you that almost everything you do on a daily basis in primary care, you can do a little bit better probably if you add ultrasound into that exam.
Thank you very much, Dr. Tierney. Just listening to you, it sounds like what you're really doing is evaluating a number of processes that would be quite frustrating to tackle blindly or just with a stethoscope without ultrasound. Am I correct in that?
Yeah, exactly. And we all still carry stethoscopes. We use them a little more specifically, but this just adds to all of those common things that we do, and we do those things a little bit better with one more tool.
All right, let's jump down to our next slide. I guess we've already covered a little bit about how ultrasound has changed your practice. If we can go to question 3. Let's see. Well, I guess this is a video showing some of the things you're doing in bedside. Is that correct?
Yeah, we can start with this. This is sort of a soft answer to that question of how does this change your practice, but we can start here. And this is, you know, sort of a pillar of internal medicine is my hand, my stethoscope, your chest as a patient, and that relationship that happens there because of that stethoscope between us. And A lot of the questions that come into this are, what happens when you put a piece of technology between you and your patient as an internist? And that's an important piece that this image, this video really shows, is that changes my practice day to day, making better patient care decisions, but overarching all of this is this idea of patient relationship and understanding. And this is a guy here who, you got 2 residents doing an ultrasound. You've got a screen set up so the patient here can see his heart on the screen. You're explaining heart failure to him, not with terms like EF and whatnot, but with here's your heart squeezing. Now let me show you mine, and here's yours again, Willie, and this is why you can't get up the stairs, and you're short of breath. So from an understanding and relationship standpoint, when this is done right as an internist, this is one of our greatest tools, and this is a huge part of how it changes our practice here. When it's done like this, you can just kind of see that this is better than me telling him, Willie, you got a heart murmur? I can hear it with my stethoscope. You just say, all right, Willie, here's your heart murmur, or whatever you might be doing. So that's a soft answer to that question. The other ways that it's changed practice, I think timeliness of information. Even in a big quaternary care center like this, biggest hospital in the Twin Cities, it makes things come faster. Even in a place where we've got a 24/7 echo tech, it makes things come faster. That PEA arrest, that's a massive PE. That answer is done in a minute, 2 minutes at the bedside in the ICU, and you can't do that even here. So timeliness of data in any setting, and it kind of goes down from a big hospital. Next step down into our outpatient clinics, where we use a ton of ultrasound, and those questions of, should I give you antibiotics or should I get a chest x-ray? We can get you in tomorrow for a chest x-ray, and then why don't I give you a prescription and you can fill it based on the chest x-ray finding, which I'll call you about tomorrow. So that workflow, that you just speed up a ton by having lung ultrasound in your outpatient practice. So timeliness of data is huge, and it's obviously most dramatic in the least resourced areas, but we staff an outpatient internal medicine, underserved, not insured clinic, and there we use it a ton.
I'm just curious, how do patients respond in that setting when you're showing them how their heart is squeezing and that it's not squeezing well enough? It must be quite a sight when you see that understanding on their face.
Yeah, I mean, especially for those of us who explain things in whiteboards and tried to draw left ventricles on a whiteboard to try to make patients understand the value of a moving structure is immense, especially when you've got a side-by-side comparison for them. So we almost always either pull up a normal clip that we save on our machines as a reference, or we pull down our shirt and show them a normal left ventricle if they're okay with that, and go back to them. And the understanding is, in my mind at least, going from sort of print media to television, which many of our patients sort of saw in real life, that transition.
Incredible, incredible. All right, well, our next question, question 3, I think is a critically important one. How does ultrasound improve upon current standards of care?
Yeah, so this is really, really important, and this is at the core of why we use it, why we put a ton of resources into it. And this slide shows a really sort of niche internal medicine way that we do this. And if we use antibiotic resistance and sort of stewardship as a core piece of how we do internal medicine well and things we have to aim for, this is our outpatient clinic, where this is that guy who had sort of this stuffy nose like I've got right now, and this upper respiratory thing, and last year got a Z-Pack and it got better and wants another one. And these people come into our clinic. Historically, about half of those patients, 55% of them, got antibiotics when they came in with those complaints. This is less than sort of national averages, 70, 75%, kind of 3 out of 4 of those that came in. And what we do now is we do just maxillary sinus ultrasound on all of these patients that come in with this upper respiratory, do I have a sinus issue, complaint. And of that population over the past 2.5 years, the study showed 28% instead of 55% ended up with antibiotics, so we don't use antibiotics in people who don't have maxillary sinus fluid, period, unless they've had some complicated surgical sinus history. And that leaves us 73% of people who come in that don't end up with antibiotics, and it's not a 10-minute discussion about antibiotic resistance with them, after which no one's really happy, the patient nor you, because you've spent 10 minutes trying to explain it, but it's just an image on the screen that say you've got no fluid here. It would be really unlikely for you to have fluid elsewhere. And very few of those people that don't have maxillary fluid and we send home without antibiotics end up coming back with ongoing complaints and eventually get antibiotics. So this is a super primary care niche, maybe just Minnesota primary care niche, but this is a big impact that goes towards that. Other pieces that apply to current standards of care, procedural guidance is an obvious one. We do tons and tons of central lines and thoros and paras, and that has just become standard of care to do those ultrasound guided. Many of us trained in times where we didn't have ultrasound, and these were all done blind. None of us who currently operate in an ultrasound-guided world for procedures would ever go back, nor want one of those done on ourselves without ultrasound. So procedural piece is huge. That's from a complication reduction standpoint, from a patient comfort standpoint, all of those are important. If you take a standard of care such as readmission, which tons and tons of primary care hospitalists at least are tied to, and heart failure readmissions. We use this from that standard of really, I think, helping reduce this, and it has to do with where are you on the day I think you should be able to go home. Do you still have some interstitial edema, some hydrostatic pulmonary edema with B lines on your ultrasound? Do you have a little further to go? And the converse of, we diurese people and the, how far should we go? Well, let's just go until their creatinine bumps. And then Willie, who's 84 years old and had a baseline creatinine of 1.5, his creatinine bumps and it's 1.9 today. So we got him dry, but now we keep him one extra day in the hospital and we increase our length of stay by a day just to make sure that if we give him back a little bit of fluid, his creatinine's going to come back down. So little niches like that, just on a day-to-day, every kind of patient we see, heart failure, etc., really helps with the standards of care right now that we're aiming for.
Dr. Tierney, great examples. I especially love the sinusitis one. That's something that's almost a plague in the emergency department with self-diagnosis and request for another Z-Pack, just like last year. So at this point, let's move on to question 4. This is another good one as well. Gets to the core of things. How is ultrasound currently taught?
Yeah, so let me take this from a not necessarily a national standpoint, but how we have done it here since 2011 when the IMBIS program started. And at the core of how you teach this, you have to start with your faculty. Your faculty have to know what's going on before you go train residents and other people. And this is just a timeline of all the different sort of types of people we've trained over the years, but inpatient and outpatient medicine, residents every year, telecardiology, nurse practitioners who are up on the Iron Rain, intensivists, etc. So at the core of this are 2 groups, your faculty and your residents. From a faculty standpoint, the key here, and a really important sort of piece, I think, from an internal medicine standpoint, is that most of us, like our program here, we've got 75 hospitalists at Abbott, and a subset of those teach, but it's a big number. And the idea that you're going to teach 40 currently working hospitalists to be able to acquire an apical 4-chamber reliably and efficiently, it just doesn't happen. So taking your faculty and splitting them into sort of 2 groups. Every faculty member getting trained to a level that they understand, the images they understand, the nomenclature, what are A lines, what are B lines, what is lung sliding, and then they know the pitfalls of it from an attending sort of standpoint. What don't those things mean? What does a dilated IVC mean, etc. So you take everyone who interacts with residents and is a faculty member, and you train them to that level. You give them a taste of what hands-on is. What does it take to get a good apical floor chamber? And then out of that base group, you select a handful of core faculty that say, you know what, I got the time, I've got the desire, I've got sort of the hand-eye, all of these pieces that I want to be able to get these images as well, not just know what the residents are talking about and other people are talking about when they show me an image that they're getting, but I want to actually get them. And you select out a group of your core faculty there that are self-motivated, because if you try to take everyone and do that, you've got a dismal success rate just because of the day-to-day work environment that all of these faculty are working in. It takes a lot of time to get there. So that's the faculty piece. You got to start there 100%, and you got to make sure that everyone that your trainees are interacting with on a day-to-day basis understand it. Otherwise, the trainees, the second part of this, really get frustrated and sort of say, why would I do this if my attending doesn't really know what to do with it and therefore dismisses it? It extinguishes a program really darn fast. So the resident side then, we train in a little bit of a unique format here. The way we do it is we have an intensive boot camp week where all of our first years come off the wards for a week's time. In their first year, it's not during orientation. They don't remember anything from that week. It's not during their first ward block. They're still trying to figure out how to log into the EMR. But a couple blocks in, we take them all off the wards for a week, and that is a core sort of learner's driving permit, set of topics with a ton of hands-on to get them over that initial sort of, I'm just a little bit uncomfortable with the probe efficiency piece. And that makes up maybe 10% of how we train. The other 90% comes from their patients at the bedside with the faculty around them that know how to do this. So at the bedside, our faculty do these with them until they're certified, and that goes on over the 3-year piece. The residents jump onto a procedure and ultrasound rotation, which is a mandatory rotation in their first year. That's a one-on-one procedures and ultrasound team. And then we have an advanced ultrasound course in the second year in the outpatient environment. So there's sort of that pillar of an initial get your feet wet, get your driver's permit, get comfortable with the thing, but the vast majority of the teaching that goes on for the residents is at the bedside on their patients with the questions that are clinically relevant to show them the impact there. And then of those topics that we train, there's a core set that everyone gets and everyone has to have to graduate from here. And then there's a set of advanced topics that people choose depending on where they're going and what makes sense long term. So that's sort of the brief high-level overview of how we train, a combination of upfront but a lot of hands-on at the bedside on real patients.
Thank you very much, Dr. Tierney. That was a great explanation, and I think gives us a good overview of how training occurs, and really one of the preeminent internal medicine training programs for ultrasound in the country. Let's move on to question 5. Question 5 is, what are rate-limiting steps to broader implementation and adoption of ultrasound by primary care providers? Also a very important question, I think.
Yeah, so I think maybe at the core of this sort of climb the mountain sort of analogy here, up at the top it says time and compensation models, and that's at least a big piece for internal medicine, maybe a little bit less so than it is in the emergency medicine setting, but the equipment's still expensive. Getting to the top of this takes a lot of discipline, commitment, study, a lot of repetitions with a mentor to get really good and to get the benefits that are there. And patient care is improved, there's no question. Costs go down, we know that clinically. The physicians, for sure, the patients are more satisfied. The problem is that all of those benefits mean that it takes longer, most of the time, to provide the care that you would have other done if you had just listened with your stethoscope for 2 or 3 seconds and not heard much. And there's not a lot of recuperation of that time cost for internists. So in the end, a system that's focused on total cost of care and best patient outcomes is the type of system where this can flourish, and this can be supported easily. A system that's based on RVUs, like many internal medicine and outpatient practices, just don't allow this to propagate in its current state. And that's for sure in the outpatient setting, where it adds some time. And so that's really at the top, is what's the model of work environment you're in, what's valued, what is the system value, is it about total cost of care for this patient, where for sure you can reduce CTs and MRIs and do things more efficiently and total cost comes down, or is it just that I need to see 25 patients today, and if I add ultrasound to 5 of them, that means I see 1 or 2 less patients because it adds another 5 minutes to your patient. So that's really at the top. Other things that are on this mountain here, sort of the personal skill, motivation, it's a huge piece. Self-learning is part of it. That's why some of the attendings will self-select to go the next step. Machine cost is coming down quite quickly as more and more people enter the market, and that still though is a reality for primary care folks. There's no question a bottleneck from a training standpoint. That's why courses like the ACP course and other courses out there are really sought after, because people need some way through this bottleneck of how do I just start getting trained. And this will self-correct over time, but we're currently, at least from a primary care standpoint, still in a bottleneck at the trainer piece. This has been improved in the emergency medicine setting, but internal medicine and primary care is behind from that standpoint. And then I think the politics and turf up there on the upper left face of that mountain is really important, and it sometimes gets glossed over because it's uncomfortable for people to talk about, especially Minnesotans here, where we don't talk about anything uncomfortable, but this is the reality of a new device that improves care and comes into a setting, that there's politics with cardiology, with radiology, there's turf pieces, whether that's procedural, whether it's diagnostic imaging, and a system that incorporates those other entities. So I can walk into the echo lab now with an image and say to the echo director, do you think we need to get a formal echo on this one? Here's what we see up at the bedside. And I can do the same thing in radiology, as can one of my residents. And that is the end game. Where this truly becomes efficient is when those politics and turf are acknowledged, first of all, not talked about like they're not there, but then the relationship between them is mutually beneficial, and in the end it's about the patient and about efficient care and safety. So all of those things are in play here, and I think the last one there, the bottom up, is just about there's this huge push from below, right? Medical students from across the country getting trained, coming to do a rotation here and wanting to get trained. And that's great. It provides a ton of excitement and energy from a learner base, but that bottom-up sort of push has got to be balanced with a safe faculty that's been trained. So a little bit of a top-down and a little bit of a bottom-up here meets nicely in the middle. But that's just my outline there of sort of the hurdles that we run into, and I think most people run into, and being aware of all those.
Dr. Tierney, very relevant to modern day practice. And that kind of segues us into the next question. How important is ultrasound performance tracking and competency assessment for new learners?
Yeah, we sort of ultra track, I guess, our trainees here, for better or for worse. But in the end, sort of after 6 years of this program, the biggest benefit of knowing where your learners are from a tracking competency standpoint is that you give these people a tool early on in their residency or early on in wherever they are in training. And this tool is not like a pen and pencil. This tool extinguishes quite quickly if you don't use it. And the biggest sort of reason we track really closely is because people who fall off sort of the increasing curve of use, just quantity of reps, however you want to think about it. Early on, they need to get put back on that curve really quickly, because if they don't, their competency and quantity and learning curves over the 3 years you're going to be training them looks dramatically different from where do they get at the end of their residency. So a big piece of tracking is about just knowing where people are doing, how much they're doing, and who needs a little push, who needs a little help to get them back on the ball. The second piece is how good are you? Are you competent? And this extends from an undergraduate medical education standpoint, which is by and large tool competency. Can you get the image? Do you know which probe to use? Do you know how to adjust the gain and the depth? Do you know what you're seeing on the screen here? Can you call that something? And then to the GME residency fellowship level, can you do that stuff, but now can you take it and know what to do with it on a patient who's hypotensive in front of you, know what to discard, what to add in from your physical exam, from your labs, and that's really about the clinical competency. So sort of a tool and a clinical competency piece that when you get to GME and CME for faculty, that's the end game. And you've got to have a way to know where people are along that. And by and large, the tool competency can be done with testing and with images and with questions, even sort of OSCE kind of questions that get at a little bit of the basic clinical stuff. But the true clinical competency of point-of-care ultrasound is done by and large at the bedside, sort of as a mastery learning assessment, and in a hospital setting. From a medical staff setting, how are people taking care of patients in the end? So really, really, really important for different reasons. But at the core of it, from a trainee standpoint, is just making sure people are doing what they need to do to stay on that bike and catch them when they fall off.
A critical topic, and one that emergency medicine has struggled with over the years, and finally has, at least in theory, down, but very, very important. This also, I think, leads us nicely into question 7, which is how will bedside ultrasound be influenced by the shift to value-based purchasing models, and how can it help providers provide better care and lower cost?
Yeah, so this is the hot topic, right? And this is about all sorts of pieces. But if you think in your brain, let me take one tool that hits on quality of care, so diagnostic quality if you want, efficiency of care, getting answers quickly at low cost and at low risk, so from a safety radiation standpoint. And what tool increases safety from a procedural standpoint, et cetera, however you want to take that. So quality, efficiency, safety, those three sort of pillars of what we're trying to aim at here going forward from value-based purchasing, et cetera. That is this tool. There is not a whole lot of other tools, single tools that you would say, you know what, this really improves quality. At the same time, it's cheap. It's reducing cost rather than increasing cost. It makes the system more efficient, and it makes my day-to-day patient in the office who's got shortness of breath, skip the chest x-ray, go home, here's your antibiotic script, fill it on the way home rather than going back to the pharmacy tomorrow. So efficiency. And then really well evidence-based from a safety standpoint. With respect to procedural safety, decreasing pneumos, decreasing needle sticks, et cetera, et cetera. And there's not a lot of tools out there that I think any of us would say, all right, here's a tool that hits all of those pieces, all of those pillars. And this is the short answer to this question, is that this is that tool. It's cheap, it's efficient, and it improves day-to-day quality, both for an individual patient but also across the system. And that's sort of the end game that we're aiming at currently.
Very much, Dr. Tierney. I think that sums up that answer very nicely, very succinctly. On to our last question of this webinar, and that is question 8. If we could ask you to discuss successful strategies used to start ultrasound programs and give some examples as well, and also talk about what are some future applications likely to make it into the internal medicine ultrasound toolkit.
Good. I think this is a good way to end because we've sort of covered the pieces that, at least personally, I think are important to making a program survive. At the core of it, you've got to have resources dedicated to doing this, and that means people up top and people who control money and people who control time, more importantly than money, but they are intimately tied together, are engaged in the reason this is important. And if that's just because the other 3 medical schools in the region are doing this and you feel like you're behind, that's one thing. But ideally, and from a long-term standpoint, you understand why this makes sense from a overall strategy for patient care. So that's the first piece. You got to have buy-in from the people who control things, deciding what to do. So this is our curriculum here. There's core stuff here, and there's advanced stuff, which is huge. And you can't do huge. You got to say, all right, here's the core stuff that we really want to start with, that every single person who leaves this place has got to be able to do. Everyone's got to be able to do a broad LV systolic function assessment, right? Not is it 25 or 30%, but is it severely down, or is it normal, or is it hyperdynamic, is it moderately down? Just the core stuff, because what we're doing and what I think places need to acknowledge if they're going to do this from implementing a program, you got to acknowledge that sort of the political line here is, don't worry, we're not taking away stethoscopes and the ability to do oscillatory percussion. Don't worry, we're keeping that just as much as it always was, but we're adding a new tool. And that's not the reality. We are doing things with a better tool now, so if I care whether or not someone's got a big spleen, and I truly care, I will look with the ultrasound rather than try to percuss it and palpate it. I love traditional exam, and I'll do that with the student at the bedside, but then I'll put the probe on it. So we're replacing stuff, and you've got to be careful from a training standpoint. One, to acknowledge that your trainees, when they leave, are not going to be trained quite as well in oscillatory percussion because they've been trained with this new tool. And you've got to pick and choose what are the core pieces that we're going to do that about. And then eventually this curriculum expands to a much bigger sort of curriculum of advanced stuff that doesn't make sense for this person who's going to go do palliative care, but 100% makes sense for this person who's going to do critical care medicine. So formative curriculum that's got those 2 components and not trying to pack too much into it. The core faculty we talked about previously, I won't echo that now, but that is the key is at the centerpiece. You got to have your faculty trained first. It's hard to tell everyone who's super excited, all the little sort of puppies down on the ground, hold on guys, we got to wait. But you've got to do that. You got to get your faculty up and running first. And then one last piece from a true primary care standpoint that doesn't always exist in an ED emergency medicine setting is that residents and internists move between the hospital and the clinic. And to think of this as an inpatient tool, then that resident goes over to resident clinic across the street and has a shorter breath patient. There's not ultrasound in the clinic, or there's not faculty in the outpatient setting who know what to do with it. You really curtail its value, and you short sell yourself. So from a primary care training standpoint, figure out what are the niches, inpatient and outpatient, what are the core pieces, and make sure this spans internal medicine or primary care, not just inpatient hospitalist medicine, if you will. So those are the big sort of overarching pieces there, and the rest of it I think we've really pretty well highlighted previously in the webinar.
Thank you very much, Dr. Tierney. I think we now have a much better view of the complexity, also the benefits of integrating ultrasound into the internal medicine practice, and some of the challenges of teaching residents. At this point, we have received a number of questions, but we're actually running short on time, partially because of the simultaneous ultrasound meetings, including the American College of Physicians and American Institute of Ultrasound and Medicine. So if you could direct any questions to info@sonosim.com, we will do our best to answer them. Thank you so much for attending. This has just been a great seminar, and I really want to thank again our expert, Dr. Tierney.
Thanks, Mike.